President of the American Society for Surgery of the Hand, Dr. Jennifer Moriatis-Wolf.
Thank you, and good afternoon. It's my pleasure to introduce our two international guest lecturers, both from Sweden. Our first one is Elizabeth Hagert. Dr. Hagert is a consultant in hand surgery and the head of wrist and hand surgery at Aspetar Orthopedic and Sports Medicine Center in Doha. She's also an associate professor of orthopedics at the Karolinska Institute and has also founded 3 private hand surgery clinics in Sweden. She is best known for her work in proprioception and peripheral nerve disorders. She's also a dear friend and mentor. This is Dr. Hagert when I met her on the Benell Traveling Fellowship in 2011 in Stockholm. So I'll call her forward now to give her presentation as the International Guest Lecturer number 1.
Thank you so much. Thank you, Jennifer, our society president and my dear friend, for inviting me to talk today about understanding the power of power. I first met Jennifer in 2011, as she showed, when she was the Benell Traveling Fellow in Stockholm, Sweden. At the time, she brought with her her husband, Doug, and her sons, Ben and David. Doug and Ben are here today. I believe Ben was 9 years old at the time. David maybe 6, 7. August in Sweden, it can be anything from cold and rainy, but this August it was wonderful. The weather was so gorgeous, super hot. So me, my husband, and my then 4-year-old daughter took the Wolf family out to our local park to show them around. So my daughter Sophia, being a typical Scandinavian child, she goes, "Mommy, it's hot, I want to swim." And zip, she undresses, stark naked, runs into the pool in the park, and I see Ben and David go, "What is she doing?" And the Wolf boys did not join her in the pool stark naked. I'm very happy to know that this did not deter Jennifer from coming back and visiting me in Stockholm again in May 2016. And the reason she came back in 2016 was because she understood the power of power. I unfortunately have no financial disclosures. I do have consent from all of my patients to show videos and images in this slide. So if you close your eyes and you think of the word power, what comes to mind? For many of us, most likely power as in energy or electricity. Or perhaps power as in a superpower nation. Or maybe the power of influence as in social media power. The word power is believed to have its origin in 13th century French, signifying the ability to act or do, and synonymous with the words strength, vigor, and might. Now, as surgeons, we can easily identify with the power of the ability to act and do. And I think especially the ortho hand surgeons here in the audience, of which I am one myself, we know how to feel super powerful and like superheroes. But in today's lecture, I want to focus on the word power as it relates to muscles and action, the power of numbers, and the power of knowledge. I want to take you on a journey through understanding power in these senses by describing 3 patient cases. We will look at a cyclist in pain, a mother afraid to hold her baby, and a young woman with hand tremors. The common denominators between these cases is that they all try to find solutions by visiting various health practitioners, various doctors, physiotherapists, occupational therapists. None of them had any findings on imaging, and none of them had electrodiagnostic studies that were positive. And all of them had been told, you have to learn to live with it. So let us begin by looking at power as in muscle power. To examine patients for muscle power is by no means anything new. The present grading system for muscle power from M0 to M5 was first described by Sir Herbert Seddon in 1954, where M0 is no muscle power, M3 means full range of motion and resistance against gravity, and M5 is full power against maximum resistance. But let's take a closer look at M4, contraction against gravity and some resistance. M4 is subdivided into 3 grades, where 4- is power against a slight resistance, 4 is power against moderate resistance, and 4+ is power against strong resistance but submaximal. So in order to find an M4 weakness, this is not going to be evident. We have to go looking for it. The principles of upper extremity muscle testing involves 4 positions. We have the shoulder, the elbow, the wrist, and the hand. These videos show the principles of how I do muscle testing in the clinic on a daily basis. I start with the shoulder. Patient is seated robustly opposite me, arms straight to test the pectoral shoulder adduction. You move out to shoulder abduction to test the posterior deltoids. Move down to the elbows. You start by testing elbow flexion, elbow extension, and elbow external rotation for biceps, triceps, and infraspinatus. We move down to the wrist. First position in the wrist is to extend the arm, ulnar deviate the wrist to test the power in the ECU. You move down again, you test wrist extension, the ECR. Turn around, you test wrist flexion, in particular the FCR. Finally, down to the hand. In the hand, we start by testing the extrinsics. Important when you're testing the extrinsics is to do with slight wrist flexion to avoid a tenodesis effect. So you test the FPL, the FTP2, and the FTP5. Finally, down to the intrinsics, testing the APB and the ADM. Doing all of this muscle testing literally takes me about a minute to a minute and a half to do. Key aspects to consider in muscle testing is to start from the roots in the neck and climb out into the trees to the furthest branches. Do bilateral testing to compare strength. Be consistent in testing and use power when you are testing your patients. And finally, expect electrodiagnostic studies to be negative, as we are most often dealing with what's called a Sunderland zero, as coined by Susan McKinnon and co-workers, a dynamic nerve ischemia or compression. The strength of doing muscle testing is that it has a proven construct validity and a high inter-rater reliability. It has an 88 to 92% sensitivity in delineating the level of nerve affliction as shown in double-blinded studies. And most of all, it is accessible. You don't need a machine, you don't need any devices, it's just you and the patient. The limitations of muscle testing include, of course, the uncooperative patient, which I guess is always a contraindication to any clinical testing. Patients with neurological disorders, and somewhat a limitation, patients with bilateral problems, as it sometimes can be difficult to delineate the level of nerve affliction as you don't have a healthy site to compare with. The patient cases that I've chosen for today are chosen to illustrate findings that we find at various levels using the muscle testing, from the shoulder to the elbow to the hand. Our first case of a cyclist in pain is one that is by no means common in clinical practice, but I do believe that it is important to understand so you can recognize it when it shows up. 5 years ago, I received to my clinic a teenager who was a junior Olympian cyclist. During a bike race earlier that year, she had raced straight into a group of cyclists that had fallen all over on top of each other. She flew over all of them, landed on the right side of her neck and shoulder, and she passed out completely. She has no recollection of the injury at all. All imaging after the trauma has been negative. Repeated nerve conduction exams were negative. She came to me 9 months after the injury, and she was on 3,600 milligrams of gabapentin a day, oxycodone, and sleeping pills to be able to sleep at night, all due to pain in her neck and arm. As you see on muscle testing, we found a pattern of weakness in her posterior deltoid shoulder abduction, in her elbow flexion biceps, and in her elbow external rotation. The pattern of weakness that we found is associated with that of the classic Erb's palsy or an upper trunk involvement, most commonly found in my clinic following a rotational or a sideways neck trauma or a whiplash. The pattern of muscle weakness showed us that our patient had a compression of the upper trunk at the anterior medial scalene interval, but also of the spinal accessory nerve as it pierces the anterior edge of the trapezius, 3 to 5 centimeters from the insertion point on the clavicle. We went on to do a surgical release through 2 separate incisions. First incision was to release the upper trunk at the medial scalene edge, as well as the spinal accessory nerve at the anterior fascial edge of the trapezius. This is her 2 hours after the procedure. As you can see, her post-op return of power is back. She can resist in shoulder abduction. She can resist in elbow flexion, and she can resist in elbow external rotation. 4 weeks after, she is off all medication except for ibuprofen occasionally. 6 months after, she has returned to competing in the World Cup. And ahead of this talk today, I got in touch with her once again. This is her 5 years after surgery. She is now a Swedish national team cyclist, and she competed in this year's Women's Tour de France. Less dramatic and many times more common is the story of our young mother who is afraid to hold her baby. This woman is a first-time mother who presented with complaints of loss of hand strength and hand control. She is afraid to hold her baby because she feels sometimes when she's holding the baby like she is going to drop her. She was seen by a GP and a neurologist. All her nerve conduction studies were normal. What we see when we're doing her muscle exam is that she is weak in her left FCR, she is weak in her left FPL, and she is weak in her left FTP2. Her case also brings me to the power of action, as the most important change ever in my clinical practice was the realization that by using Wallant or wide awake hand surgery, we can monitor action and power intraoperatively. The pattern of weakness of FCR, FPL, and FTP2 is seen in Lacerda's syndrome or proximal median nerve compression at the level of the Lacerda's fibrosis. This surgery is best done under Wallant using tumescent lidocaine epinephrine anesthesia, about 20 to 30 cc's. A 1.5 to 2 centimeter incision is placed right over the Lacerda's fibrosis, and then it allows for testing power before and after release. A cadaveric study that was published earlier this year could show that division of the Lacerda's fibrosis alone led to over 80% decrease in median nerve pressure at the elbow. Our patient consented for surgery. At 12:12, we tested her power in her FTP2, in her FPL, and we did what we call the A-OK sign. So we asked her to hold like this and resist as I'm trying to pull out. And so you see, she cannot resist at all. We went on to release the Lacerda's, and at 12:19, we're testing the power again on the table, and it's back. The the immediate return of power in Sunderland 0 types of nerve compressions is by no means limited to the Lacerda syndrome, but something that we see in all dynamic nerve compressions, including return of ECU power after radial tunnel release, the return of FTP5 power after cubital tunnel release, and the return of EHL power after a common perineal nerve release under Wallant. The return of intraoperative power following Lacerda's release was recently documented in this study from Chile, where 24 patients undergoing simple Lacerda's release had their FPL and FTP2 power measured intraoperatively before and after release. Following simple Lacerda's release, the FTP2 had an average of 96% increase in power, and the FPL an average of 65% increase in power. Now, since I'm speaking of research, it brings me to the power of numbers. One question that I often get: are proximal median nerve compressions Lacerda syndromes, or are they pronator syndromes? And what do we even know of the former, as we've known about the latter since the 1950s? Well, if we look at numbers, in 2023 alone, there have been publications from 4 different continents reporting on over 600 surgically treated Lacerda syndromes. All surgeries were done using only isolated Lacerda's release, and all studies report significant improvements in DASH score strength and visual analog scale for pain. If we look at pronator syndrome, between 2013 to 2023, so in the last decade, there were 69 patients treated for pronator syndrome through an extended nerve release, where the studies were mostly case reports and with variable outcomes. In the largest cohort to date on Lacerda syndrome, 275 Lacerda's releases were analyzed from a 10-year period. As Dr. Atroshi is speaking about the carpal tunnel syndrome after my talk, I must mention that 26% of these cases had a combined carpal tunnel and Lacerda's release, and 13% had a prior failed carpal tunnel release. All but one patient had intraoperative immediate return of power. 2 of the 275 patients had an intraoperative finding of the median nerve within the pronator teres muscle, or a so-called pronator syndrome. However, more than 80% of the patients reported spending at least 5 hours a day with their arms in hyperpronation and repetitive finger motion. The conclusion may thus be that most proximal median nerve compressions are not pronator syndromes, but rather syndromes of pronation. The publications arising from many different continents is also evidence of the power of knowledge. And this knowledge includes the awareness of a standardized examination of nerves in the upper extremity, including manual muscle testing to delineate the level of nerve compression, as it has a high sensitivity, sensory provocative tests, in particular the scratch collapse test, which has a high specificity, as shown in a recent systematic review from Hand in 2023. And finally, pain at the level of nerve compression for final verification. The dissemination of knowledge and application thereof can be illustrated in the next case from my friend and colleague, Dr. Jean-Paul Brutus in Montreal, who after learning to examine for power, could diagnose and treat this patient. A 19-year-old student presented to his clinic with a 7-month history of onset of tremors and periodic ulnar-sided forearm hand and pain. She had 3 electrodiagnostic studies, which were all negative. Her MRI was negative. She was seen by 7 urologists and was not given a diagnosis. On muscle testing, she had weakness in her FTP5 signifying a cubital tunnel syndrome, weakness in her ADM signifying a Guillain canal nerve compression, and she went through a subsequent ulnar nerve release both at the cubital tunnel and Guillain's canal. To the left is her intrinsic hand function after surgery. To the right, the tremor seen in her hand before surgery and at a 2-week follow-up. So, when should we test for power? I would say in any patient complaining of numbness, upper extremity hand aches or pains, loss of endurance, loss of dexterity, yes, even in our so-called clear-cut carpal tunnel cases. And why? Why should we test for power? Well, simply for the sake of diagnosis. As beautifully illustrated in Lisa Sanders' novel called Every Patient Tells a Story, Medical Mysteries and the Art of Diagnosis. As Dr. Sander writes, getting the diagnosis right is the most important thing you can do for your patient. If you don't get the diagnosis right, you will never get the treatment right. I would like to conclude this talk with a dedication to my father, Professor Carl Hagert. Born in 1933, he did his hand surgery training with Eric Moberg, 1967 to 71, a fellowship with Al Swanson in 1969. He has been an ASSH member since 1990. He was the Willie White visiting professor at Pittsburgh between 1998 and 2001. And he was honored as an IFSSH Pioneer of Hand Surgery in 2019. He has taught me more about diagnosis than any other mentor of mine. But most of all, he has taught me about the power of compassion, the power of seeing your patient, listening to your patient, touching your patient, and dedicating time to find the diagnosis. As in the quote from 400 BC by Hippocrates, which still holds true today, cure sometimes, treat often, comfort always. I love you, Dad. Thank you.